Hello, everyone, and thank you for joining us. Welcome to our July ALS Learning Series from the Les Turner ALS Foundation. Today we're going to have Dr. Driss, a neurologist, speak on advancements in clinical research for ALS. Just as a reminder, all of you are off camera and muted, so just sit back and enjoy the presentation. It should last about an hour, and you will notice to the right of your screen there is a chat feature. So feel free to drop any questions that you may have in the chat, because we will have time at the end of the presentation to go through those. All right, a little bit about myself. I'm Anne-Marie Doyle. I'm the Community Education Manager here at the Les Turner ALS Foundation. And again, I just want to thank you for joining us today. Before we get started, I just want to do some quick thank yous. So the ALS Learning Series is made possible because of a donation from the Gilbert and Jacqueline Fern Foundation and our industry partners, Mitsubishi Tanabe Pharma America. So a little bit more about the Les Turner ALS Foundation. We are leaders in comprehensive personalized ALS care and research. We realize that people living with ALS may feel overwhelmed and unsure of what questions to ask and what to do next. And that's really where our support services team shines. Our team is comprised of knowledgeable and compassionate nurses and social workers with many years of experience helping people with ALS and their families kind of be guided through this journey. We offer a variety of services, including care visits by ALS support coordinators, need-based grants, and connecting people with community resources. At the Lois Insolia ALS Clinic at the Les Turner ALS Center at Northwestern Medicine, we offer access to enrollment in clinical trials and a multidisciplinary team to provide comprehensive support. If you're looking for more information on symptoms and care options or interested in browsing past learning series topics, visit us at lesturnерals.org. We know that making decisions about ALS care can be really overwhelming, but again, we're here to help. The Les Turner ALS Foundation developed My ALS Decision Tool to help you learn about your options. We currently have modules on breathing support, nutrition support, and launched a genetic testing support module in May of this year. Again, all of this can be found on our website, lesturnерals.org. And because we are talking about clinical research today, we'd be remiss not to mention joining the National ALS Registry. This allows people with ALS to get involved in research and help future generations. Research today may lead to a better understanding and potential treatments for tomorrow. By signing up for the National ALS Registry, being counted, and taking risk factor surveys, people living with ALS can help everyone find these answers. And that is available at cdc.gov /ALS. And now it is with great excitement I am so excited to introduce you to Dr. Driss. Dr. Driss is an associate, or I'm sorry, she is now professor of neurology. Congratulations. And the director of the Lois Insolia ALS Clinic at the Les Turner ALS Center. She's also the director of the Neuromuscular Clinical Trial Program and has about 20 years of experience treating patients with ALS. Dr. Driss, welcome. I am going to make you host, so you can share your screen in just a moment.
Fantastic.
Yep.
Very good. Well, thank you, Anne-Marie Doyle. Anne-Marie, sorry, for your kind introduction. My professorship starts September 1st. I'm technically still an associate professor until September 1st. Let me tell you how excited I am to kind of present today and take you through really some of the things that happened over the years and try to explain them in a way that would be not overwhelming. I know there is a lot of information out there, many webinars, and it's sometimes difficult and very overwhelming to make a decision of what to do and what to listen to. So what I was hoping to do during this presentation today is really go back to basics and review the ALS pathophysiology. I also want to explain to you how hard it is to do clinical research in ALS. And I want to really illustrate those points by going over one positive trial and one trial that is in progress. And at the end, I want to finish by discussing the status of clinical research at Northwestern. So for the patient who go to our clinic, we'll have an idea about what's going on. So let's jump in. You hear about motor neuron disease, right? ALS is a disease where the motor neuron degenerates. But what is a motor neuron? And I thought maybe showing you the picture of these healthy motor neurons here in this one, in the spinal cord, you could see how this is a nice, healthy motor neuron. This is a different stain. And we know that ALS happened because these motor neurons, and these motor neurons are neurons that control movement and allow us to move. They in this case, this one looked very healthy compared to these ones here, where you can see, you can really infer that these motor neurons don't look healthy at all. They are sick. There are things going on in their cytoplasm. This is the nucleus. This is the cytoplasm of the motor neuron. So in the nucleus, this substance is not there, but it's in the cytoplasm. It can be threads-like we see it here, or it will have a blob-like appearance. And we call these inclusion. I'm sure you've heard about them before. They're called inclusion. We think that these inclusions are bad, and they may be the reason that the motor neuron degenerates and dies. We are able to see this is because we have access to patients' brain and spinal cord after they pass away from ALS, and when we stain them, this is what we see. And as I said, you can see here a very healthy motor neuron, and this one that is unhealthy with many depositions inside it. It doesn't work properly, and when it doesn't work properly, the muscle attached to it will actually shrink and not function properly, and that causes the weakness that the patient experiences. Many patients, when ALS starts, they start feeling weakness in their arms, in their legs, in their different muscles, and that is due to this motor neuron that is not working properly and causing the muscle not to work also. So how do we know what we know about the function of the motor neuron, and what are the things that go wrong that lead to the degeneration of the motor neuron? What happened about 30 years ago is we discovered the very first ALS link gene, SOD1, back 30 years ago. And since we have discovered many genes, over 50 genes implicated either directly or indirectly in ALS. And these genes have been very important in shedding the light about the way the motor neuron work. With every gene we can actually model in these different models, from cell to yeast to fruit fly to zebrafish to the mouse, and they teach us about the different pathways that are involved to make the motor neuron work properly. So over the years, we have, by discovering all these genes and by making models and going all the way even to the induced pluripotent cell, the stem cell from the patient, and changing that into a motor neuron, we've been able to understand all the pathways that are involved, that if they go wrong, the motor neuron will degenerate and die. Unfortunately, what we are missing is really the sequence of events. We don't know what the trigger is and what are all the events that are put in place that will lead to the demise of the motor neuron. Basically, we are kind of looking for the needle in the haystack. We want to get to that moment of finding exactly all the processes that lead to the degeneration of the motor neuron. So I hope I gave you a little bit of an overview about our understanding, current understanding of how the motor neuron degenerates and why it is really difficult to really know exactly what is it. I mean, we know a lot, but at the same time, our knowledge is still lacking. So what happened about a few years back, and again, thanks to the study of the brain specimens from patients at autopsy from patients who died of ALS or frontotemporal dementia, a protein called the TDP43 was discovered, and that protein is normally sits in the nucleus, but in the patients, we can see that it leaves the nucleus but goes into the cytoplasm. It accumulates. It causes these inclusions that I showed you earlier that make the motor neuron not work properly. And again, I mean, that protein TDP43 is very, very important for the function and the expression of certain genes that are crucial for the health of the motor neuron. So if that protein is not there in the nucleus, it goes into the cytoplasm, it's actually not doing its work, not working properly, not doing its function to be important for gene expression. And then once it's in the cytoplasm, it actually may help trap other protein, and its function is decreased. So there is a new understanding that started about 3-4 years ago. There was a kind of a breakthrough that really helped us understand a little bit more how this TDP43 is linked to ALS. It seems like it's important for the expression of genes that are crucial for the motor neuron, and when these genes are not expressed properly, they cause the motor neuron to die. We also do know that when the cell is stressed, there is an activation of certain pathway. One of them is called the integrated stress response, and those pathways also are crucial for the accumulation of TDP43. So not only does it leave the nucleus, which sometimes can happen in normal cases, it cannot go back because it gets trapped, and it may also help trap more protein. We do have a little bit of better understanding now by studying this specific protein, and there are many clinical programs, drug development programs that are targeting this pathway specifically. So let me just change gear a little bit and tell you about all the challenges we have in doing clinical research in ALS and developing new therapies. So I just went over how difficult it is to really understand all the kind of steps that are put in place and lead to the motor neuron degeneration. So it's not like you have an infection and you have an abnormal bacteria and you give an antibiotic and you're done. In ALS, unfortunately, and in many neurodegenerative diseases, all the processes are not very well understood. We do have ideas, like I showed you earlier, but we don't have the full picture. And we'll go over other things. Some of them are, for example, disease heterogeneity. There is a delay in diagnosis. We don't have good measures of disease progression. We don't have good biomarker. And at the end, we'll talk about our clinical trial design. So let's see all these steps one by one in more detail. So as you know, ALS does not discriminate. It affects can affect anybody, even famous people have been affected by this disease. But really here, I want to highlight how different it is between Lou Gehrig and Stephen Hawking, who both had ALS, but both had really very different disease progression. And you do know that ALS is very heterogeneous, meaning very different from patient to patient. If you sit in a support group or talk to other ALS patients, you will discover quickly that every single patient has their own disease. Not two patients are alike. And that's sometimes because the disease can start in different places. Sometimes it can start in the arm with the function of the hand, for example, in the legs, weakness of the legs, in the tongue, in the muscle of the speaking and swallowing. It can affect any person, age, and of course, as I showed earlier, the progression of the disease could be very different from patient to patient. So this makes it a little bit hard to study something when people are completely different. Sometimes you ask ourselves, are we dealing with one disease or are we dealing with multiple diseases? So as we are designing clinical trials, we have to find a way to, I would say, compare apples to apples, make sure that we include patients that kind of look alike as much as possible. Now, there is something that is now very, very important, especially in these past years with the development of new therapy. Now, when the patient come to us, we need to start them on disease that have been FDA approved to slow down disease progression, like Riluzole, Relyvrio, and Radicava. So it is important for us to see our patient as early as possible so we can start them on this medication. You do know that this sometimes can take up to 6 months sometimes, and it's a long time. So why is there a diagnosis delay? The diagnosis of ALS actually is not that difficult. It's easy, but patients usually have, even though they are different in their presentation, if you talk to patients, you'll discover that most of them have had the same journey, and they've gone from doctor to doctor until they got to the ALS clinic. And on average, when I see my patient, their symptoms have started within a year of their visit. That's been true over the years, unfortunately. This is also well highlighted in the study done by Dr. Pioro. Dr. Pioro is one of our ALS physician. He's been at the Cleveland Clinic before joining Northwestern, and when he was at the Cleveland Clinic, he and his team did a review of the literature to look at this diagnostic delay, and he found that it takes 10 to 16 months for patients from the time the first symptoms start to the time they come to the ALS clinic and get a formal diagnosis. Unfortunately, it does take that long. And they all are referred to either orthopedic doctor, ENTs, rheumatologist, neurosurgeon. And what is also really sad that if they see a neurologist, the neurologist is not the last step. Sometimes that also can cause significant delay in the diagnosis. So why is that? I mean, some of it is because I said the diagnosis is not that difficult, but many physicians want to make sure that they don't miss other things before giving a patient a diagnosis like ALS, and that can create a delay. But the other problem is we don't have a PSA, unfortunately. You know, if you go to your primary care physician, you do a blood test. If you're a male, they check your PSA. If it's high, they will refer you right to the urologist, and they will check you for whether or not you have prostate cancer. In ALS, we don't have any marker like that. We don't have a blood sugar. We don't have a high blood pressure number or a cholesterol number that will indicate that this is what's going on. You have to rely on your clinical skills. And I will go back to the PSA is what we talk about when we talk about biomarker, for example, and I'll talk about biomarker in a second. Now, how do we measure the disease progression in our patients when they are involved in clinical trial, especially when patients progress very, very differently? They can be very slow or they can be fast. So we have to have tools that could help us discriminate between both. Over the years, we used a measure called the ALS Functional Rating Scale Revised. This is, I'm sure that many of you who have gone to ALS Clinic have already filled something like this or been asked this questionnaire. So this is a questionnaire that has 12 items that is supposed to look at everything, your speech, your swallowing, your arm function, leg function, respiratory function, and the highest number you can have is 48 when there is no weakness, and then that number over the progression of the disease will go down. On average, when we look at the placebo in clinical trial, they have progressed over the years, but 1 point a month, but we don't use that as a strict benchmark. Again, I said every single patient is different. This scale is what we use as a primary endpoint. That means when we say we're going to test a drug and we're going to see a difference, we want to see a difference on this scale. It has some limitation. It's actually good. It's easy to administer. You can do it over the phone or through telehealth. You do need training for the patient, for the people who administer this test. And it is not very sensitive early in the disease and late in the disease, unfortunately. Also, like a change of 1 point in one patient may not be the same as another patient. Like the same score, two patients having exactly the same score may not have the same distribution of weakness, for example. And to kind of help with the difficulty and with the shortfalls of this questionnaire, Christina Fournier at Emory came up with this new scale called the RODS, who's supposed to be addressing the difficulties that we see with the ALS-FRS. It's going to be used in clinical trial. It is actually currently used in clinical trial to see how it does compared to the ALS-FRS. But the ALS-FRS has been used and validated over the years. It's a primary endpoint, but this new scale will be just an exploratory to see how it does before we move that to kind of higher level. And you notice if you are enrolled in clinical trial and then come to a visit, you get the ALS-FRS, you may get the RODS now, and we do measure your breathing. We do measure your breathing to assess the strength of your diaphragm muscle and your breathing muscle as part of clinical visit anyway. But we do use that in the clinical trial to see how the progression of the breathing is in a clinical trial as well. And the other thing we do, and many of you probably had it, I'm sorry, my picture is blurry, is measure this, the strength of the muscle using a device called handheld dynamometry that gives us, supposed to be more objective than us physician pushing on the patient. But we do have these, what we call endpoint or outcome measures. They're not great. That's why we cannot rely only on one, and we use multiple ones and trying to see a signal in any one of those. And there are many other endpoints that are being developed, mainly digital endpoint, an endpoint that hopefully will detect change without doing anything, like watch that the patient will wear, for example, and things like that. And now I'm going back to this notion of biomarker. I mean, things will be easy. We'll diagnose our patient much earlier. We'll have an idea about the disease progression. We will know if a drug works or no if we had a biomarker. And the best place to look for biomarker is the spinal fluid. And why is that? That's because the spinal fluid is where the brain and spinal cord live. So when the motor neuron degenerates, it releases substances. And the first place where we can find these substances will be in the spinal fluid. They do, if they're released at a higher level, they will make their way into the blood. So years back, we used to measure neurofilament only in the spinal fluid. But now, thanks to the improvement in ways, in methods of detecting neurofilament in the blood, we can detect it in the blood. And at this point, we do know that the change of neurofilament, for example, in the blood does mirror that of the CSF. So we don't need CSF anymore to measure neurofilament. We can do it in the blood. But this is not true for many other biomarkers that we're still learning about, and it's really crucial to study them in the spinal fluid. You also use other, urine, for example, is important. We do also use the blood and look for marker in the blood as well. Biomarker will tell us if the disease is there, how the disease progressed, but the most importantly, the biomarker will also tell us if we are hitting one of these pathways, that with the drug that we want, and if we are changing the fate of the motor neuron, if we are protecting motor neuron, then the biomarker that reflects that the motor neuron is suffering, like the neurofilament, for example, will decrease in the spinal fluid. So neurofilament are great. I'm sure you guys have been hearing about them, but they're non-specific. What that means that any injury of the brain or the spinal cord will cause the neurofilament to go up, not just in ALS. So it's we need to have biomarkers that are more specific, that tell us exactly what happens in the motor neuron. Other ways to find biomarkers, they don't have to be all kind of fluid biomarker or wet biomarker. We can use imaging, either through MRI or PET scan. Here, there are compounds that tell us that there is certain inflammation in the brain that we can follow with the PET scans. But you can understand this is a little bit more difficult to use compared to just getting doing a spinal tap and getting a little bit of spinal fluid or doing a blood test. So let me stop here for a second and try and really explain all these points that I was trying to make through the analysis of the Tofersen trial. So you are all aware that Tofersen, which is called Qualsody now, has been developed through a phase 3 that was followed by an open label extension phase and received accelerated FDA approval for the treatment of familial ALS due to SOD1. So I thought maybe if I go through the paper and the graph presented in the paper and show you the results, it will help really drive home the point I was trying to make by explaining the challenges of doing clinical trials in ALS. So Tofersen is actually a second generation ASO. The first study, the first generation ASO was done in '93. So it took time to tweak that ASO a little bit. So the very important thing here is this antisense oligonucleotide, or ASO. It's a gene therapy, targets the SOD1 mRNA. So in familial ALS, as you know, 90% of ALS is sporadic, 10% is familial, and in this 10%, patients who have mutation in the SOD1 gene are only 20% of the 10%. And really, it's about 1% of all ALS that is due to SOD1, about. In this case, we do know who the bad guy is. It's SOD1. We know when SOD1 mutates, it produces an abnormal protein that contribute to the degeneration of the motor neuron. We don't know what are the steps that lead to that, but we do know that having mutated SOD1 is bad. So this ASO is targeting specifically SOD1. And so it is only in patients who have familial ALS due to mutation in this gene. So this study started back in 2019. They enrolled 108 patients with SOD1 mutation. So this makes it, remember we talked about heterogeneity, this makes it a homogeneous group, like all the patients look alike. But they want them to even look more alike, but by enriching their patients with 60 patients who had rapid SOD1 mutation. So for SOD1, even though it's the same protein that is mutated, depending on the mutation, you can have patients who progress fast and patients who progress slow. So they wanted to have patients that look alike even in the progression, and they recruited patients who had SOD1 mutation known to cause rapid disease progression. And again, here you can see they had to choose their primary endpoint, and they had to say when they're going to study that primary endpoint. So they had, when you design a clinical trial, you have to put all the cards on the table. And that's what they're doing. They're saying we'll study the patient for 28 weeks, and we'll compare their ALS FRS when they, at the end of the study, compared to the beginning of the study, and compare the patient to the placebo. So we'll see the change in the patient and in the placebo in the ALS FRS. They have, you could choose as many secondary and exploratory outcome as you want, but what matters really is your primary endpoint. So as secondary endpoint, they chose SOD1 and neurofilament in this case. And it's important to choose SOD1 because if you say you're targeting SOD1, you want to know exactly that you're bringing that protein down. They chose NFL, thinking that if we bring SOD1 and if we make a difference, maybe less motor neuron will die, and if less motor neuron will die or will suffer, then the neurofilament number will come down. So let's see. This is the graphs presented in the New England Journal. So I thought I will kind of go through them one by one. So first, they said, we want to drop SOD1. And we call SOD1 the target. And in this case, you could see in this graph that patients who received drug from the beginning are labeled here in red, and patients who started on placebo are in blue. At the end of the 28-week period, everybody received drug. So patients who were on placebo were switched to active drug. And and this level here represents the level of SOD1 in the spinal fluid. Yes, SOD1 in the spinal fluid. So you could see around 8 to 12 weeks that the level in the patient who received the drug, the level of SOD1 is dropping, and staying low throughout. However, the patient who received placebo, their level did not change it kind of a little bit, did not go down, but then when they were switched to the active drug, it did go down. So this is very important because they said, we're going to hit the target, and they did hit the target. They caught the bad guy and put it behind bar. In clinical trial design, this is called target engagement. And in this slide here, we can see that their drug did achieve target engagement. And this is very important because if a drug doesn't work, and if the drug didn't even reach the target, then how are we going to know what's going to happen, right? So that's the very first step. We want to make sure that the drugs that we develop and we give them to patients in clinical trial, we have to have a way to find out that our drug did reach their target. That's important. So this is the first step. Now, what happens to the neurofilament? Okay, so it is interesting that the same thing happens to the neurofilament. Around 12 weeks mark, patients who received the active drug did drop their neurofilament, and they maintained them low all the way. Definitely, there is a big difference at 28 weeks. This continued up to a year. Now, what happens to the patient on placebo? The neurofilament maybe went up a little bit. They did not go down. But then at the 28-week mark, when they were switched to the active drug, their neurofilament did drop. Okay? So in this case, we did show that we had target engagement with bringing SOD1 level down. We did show that we altered the biomarker, which is neurofilament. So hopefully what this means is if neurofilament levels are going down, that means less cells are dying. That means we're probably protecting function, okay? Well, let's see now what happened to the functional measures that are important. All this is good, right? But we want this to translate in improvement in strength, improvement in breathing, and all these outcome measures we talked about earlier. So let's go through these one by one as well. So let's look and see what happened to the ALS-FRS, okay? Although patients who received drug from the beginning progressed slower than the patient who received placebo, unfortunately, at the 28-week mark, this difference was not statistically significant, okay? Because the trial was designed to look at the difference at 28 weeks, and because the primary endpoint was ALS-FRS, at this point we say this is a negative trial because this trial did not reach its endpoint, despite everything I showed you before. So let's see what happens at the 52-week mark. Now, if we extend the trial a little bit further, we could see that the difference gets bigger and bigger. The statistics here get a little bit confusing, but it's obvious now that patients who received drug from the beginning have better function than the patient who received placebo from the beginning. So it tells us something important here, that maybe 6 months are not enough to see a change in function in patients who have ALS, even if the drug can change things, even if the drug reaches the target, even if the drug alters the biomarker, even if the drug is going to work, we may need to look at the patients longer than just the 28 weeks. Recovery or healing may take longer time to happen. This is a very important lesson. let's look at the other endpoint. So we see the same thing with the breathing, actually. The difference at 28 weeks is not statistically significant, but if we wait longer, the difference becomes even more important. We see it also in the handheld dynamometry. We even see some improvement, very tiny improvement there, very tiny improvement in strength here. This is actually, it goes along what the patients in the study do feel. It is, if you stay on it longer enough, there is some kind of, maybe we're hoping, not just slowing disease progression, but also repair. We're hoping for that. So what are the lessons of this study? I think this is a very important study, and based on these results, the FDA granted Tofersen, now Qualsody, accelerated approval. That means we need more evidence to get the full approval. And the lessons are that even though the pathophysiology of ALS is difficult, even if we don't really understand all the steps, we did things that helped us get closer to a drug that may make a difference. So we studied a population that is very homogeneous, the population that has SOD1 mutation. We only focused on one type of patients, hoping that they really look alike as much as possible. We had a target. We had that needle in the haystack. In this case, it's called SOD1. And also we had a biomarker. So those are the things that we need to design successful trials in the future. Find ways to sort patients in a very homogeneous group as much as possible. Sometimes we don't even think. You ask ALS clinician, and we ask ourselves, are we dealing with one disease or multiple diseases? Can you imagine treating multiple diseases with one drug? That doesn't make sense. And we have to have ways to know that we engaged our target, and also we need to work hard to develop additional biomarkers. Let me walk you through another study. And I'm sure many of you remember or have heard about lithium. Years back, lithium was shown to maybe slow down the progression of the disease in one trial, and then that, unfortunately, was not replicated. Many trials in the US and in Europe did the same thing, but could not show that lithium was able to slow disease progression. And this study is an interesting study. It's a little bit outdated, but looked at all the study, combined all the results of all the lithium study in one kind of paper. And it does show clearly that there is no difference between patients who take lithium and the placebo. But then when they looked, they were trying to go back and really look at the data through many, many things, understand why was this study positive, but then we couldn't replicate that result. There must be something that we are missing. And when they did that, they discovered there is a group of patients who have a specific DNA change called UNC13A. And this is, we know that patients who carry this gene or a change in this gene have a shorter disease and tend to be bulbar, may have frontotemporal dementia. So they have a little bit more aggressive disease than the rest of the ALS patients. So when they looked at their data, they noticed that the patients who have this change in this gene, UNC13A, their survival actually was much better with the lithium. When they compared the patients who are carrier of these gene change to the patient on placebo in the lithium study, so they compared the two groups, they saw that the patient who received the lithium and had this change lived much longer than the patient who did not receive lithium, the placebo, and also had this change. So based on this, they were able to pick a very homogeneous group of patients that have this DNA change. And there is a trial now with lithium in Europe and Australia enrolling only patients who have this gene change. So it is important to find ways to try and sort patients in categories like this, for example. This is what we used to do before, just give everybody the same thing and hope that we we find something. It doesn't make a lot of sense, right? We have to figure out ways to what we call stratify our patients, divide them in groups, and maybe every single group will respond to a specific drug. So this is really the future. This is what we are trying to do now, that we are doing with this lithium study that is ongoing in Europe and Australia. So remember, I showed you this picture before, and I want to show it to you again because I want to highlight that to date there is about 40, at least 40 clinical trial programs ongoing in Europe and in the world, basically Europe, and mainly in Europe, Australia, and the U.S. And you can see that there are treatments that either are going to be tried or are being tried to target all these pathways that we know go wrong in the motor neuron. We can see that some of the drugs that we are using, for example, like Relyvrio, that can target the mitochondria here, or we can have Riluzole that target the glutamate toxicity, or Edaravone right here that can affect oxidative stress. But you can see here how really this is complicated, but we are working very hard to breach these knowledge gap by doing all these clinical trials that target so many pathways. So we've gone through trying to explain the difficulty of clinical trial design, the challenges in clinical trials by going over how to choose a group of patients that we think may respond to a specific drug, how to, even though we don't understand the pathophysiology of ALS, to be very careful about choosing a target and making sure that the drug does reach the target, and trying to discover biomarkers that will help us identify patients early, put them on the drugs that are FDA approved to slow disease progression, and then enroll them in clinical trials. The last thing I didn't talk about is really about the clinical trial design. And I know that many of you are familiar with this, but I think there are patients who probably have been recently diagnosed with ALS that have not heard it. I'm going to go over it quickly and hopefully leave some question at the end. So I just want to talk very quickly about the platform trial. When we, the definition of insanity is doing the same thing over and over and hope that it will work. So over the years, we've been doing that. We've been using this almost the same clinical trial design that we changed with every single trial, even negative, teach us a lot about how to do clinical trial in the future. And I hope I demonstrated that by going over the SOD1 trial. But at this point, 5 years ago, the community came together and decided maybe we should look outside the box and maybe we should do things that have worked in other diseases that are complex, like cancer, for example. And that's where the idea of starting to do a platform trial in ALS came from. And really traditional, and again, the reason to do that is because there is a need now to access, there is so many companies interested in the ALS space, and there is a need to do clinical trials faster and test multiple drugs to speed up the whole clinical trial development in ALS. So traditionally, what we used to do is really build an infrastructure and then for a trial, and it takes at least 9 months to a year to do that, and then tear it apart and start all over again. Really what platform trial does, it helps to have an infrastructure that is there, and instead of having to go over and build it every time you finish a trial, you just add drugs one by one and test them individually, and you just enter new drug in the cycle every time. And there is way to know quickly also if the drug works or doesn't work, which is important. It has the advantage of making the study way more efficient. It does really decrease the number of patients needed, and because we are sharing the placebo across the drugs that we are trying, it brings the number down, and by bringing the patient number down, it brings the duration of the trial down. When it started about 3 years ago, we had about 54 sites, and now there are more than 70 sites And just to kind of show you what was accomplished thanks to the platform trial in the past 3 years, knowing that this was launched really in the height of the pandemic, it is incredible that we learned very quickly that Regimen A didn't work, which is interesting. So patients who were in Regimen A could be eligible to go to other trial or go to other regimens. Regimen B also unfortunately was negative, but Regimen C and D showed positive signals and will be studied in further trials. This regimen is still ongoing, and now we are actually recruiting for these two regimens, F and G. So these are kind of 7 compounds that have been and are being tested in just 3 years. 3 years is usually the time to do just one clinical trial, usually. So that is very interesting. The efficiency is just incredible. And currently, we are a site for platform, and the regimen we are recruiting for is Regimen F. It is developed by Calico in collaboration with AbbVie. It's a phase 2/3. Most of the studies are phase 2 trials in the platform trial, but some of them could be like in between. It's supposed to enroll 240 patients, and it does involve a spinal tap to understand really if these compound is reaching its targets. Remember, we talked about that earlier. And because we're sharing placebo with other regimen, as I said earlier, patients have 3 and 4 chance to be on active drug and 1 chance to be in placebo. And after the 6 months of placebo-controlled phase, patient will be placed on an active drug. It is taken only once daily. It's an oral drug, so it's easy to administer. And we think that what happens with the cell, the motor neuron, it has something called, it's chronically stressed. And when it's chronically stressed, it has a pathway called the integrated stress response that is activated. And this compound is hoping to modulate that, to maybe regulate that integrated stress response. And marker of integrated stress response are only present in the CSF. We can only measure them from the CSF. And that is why it's important to study the spinal fluid and see if we change that, we're doing what we're supposed to do. So I spend a lot of time talking about interventional study. These are clinical trials. Usually we give a patient a drug. We compare patients when they take the drug to the patient who don't take the drug, the placebo. So they're called interventional studies. We do an intervention. But clinical research also involves another part that's called observational studies, and these are very, very important for ALS. A few years ago, we participated in Enter ALS. We are actually geared to join Target ALS, and we've been participating in the Natural History of ALS Consortium, as well as the PLS Natural History Study. So these don't require the patient to do much. We take the information from the patient, sometimes from the chart. We do exams. We need to follow the patient prospectively, like when they come back to their clinic visit every 3 months, we take the same information. We usually do it in a way that we can share the information with other centers, hoping to understand the disease better. But what's happening with these natural history, they're giving us real-world data on ALS patients, and there is really interesting statistics that could be done that could use these patients that enrolled in observational study as what we call external placebo and understand the progression of the disease, so we can add that to the clinical trials that the clinical trials that are ongoing and see an effect better, hoping to decrease that placebo. We cannot eliminate placebo, unfortunately, because of that heterogeneity. One way in clinical trial to resolve that is to make sure there will be a group of patients who will not receive the drug. But can we get that number of patients smaller and smaller and smaller? And some of these observational studies will help us to do that. Now, Enter ALS as well as Target ALS are working very hard in developing biomarkers for the disease. Remember, I told you biomarkers are important. If they help us diagnose the disease early, help us follow the prognosis, and understand if drugs are working or no. But all this is great. But if a patient comes to me today and tells me, what can I do to slow down my disease progression? What do I do with my symptoms? I think the most important thing, we cannot do good clinical research without good multidisciplinary care. And it is important for the patient to be seen not just by the neurologist, by the pulmonologist, by the occupational therapist, the dietitian, the speech pathologist, the social worker, the patient support staff that we have at the Les Turner Foundation. So this is important, and it has really been proven multiple times that patients who attend a multidisciplinary ALS clinic live longer, they have a slower disease progression, and they have better quality of life. And it is important to follow the respiratory changes, because we know that early respiratory management does slow disease progression. It is important to address nutritional change. We know that weight loss is bad, and it does cause faster disease progression. So attending the multidisciplinary clinic and seeing our our allied professionals is very, very important. And it is really the one most important thing to do for patients to kind of try slow down their disease progression. Clinical research comes on top of good multidisciplinary ALS care. And I think that's all I have. I am ready to take any questions.
Thank you so much, Dr. Driss. What a beautiful way to end and enter our Q&A. I think you leading and also ending with that hope and talking about clinical trials that are happening in the United States and Australia and Europe. It's exciting to know that we have a team of international researchers really focusing their time on trying to get to the bottom of ALS and really essentially find a cure. So let me pop these questions out here. Somebody asked, you mentioned that diagnostic delay, and is there anything that we as a community or we as educators can do to better educate maybe those general practitioners or ENTs or therapists in hopes to getting people to that multidisciplinary clinic faster?
Yeah, it is actually a subject of a lot of research, trying to figure out ways to better educate the community about identifying ALS better. I think there is a lot more awareness now than it used to be. We are trying really to focus on our medical students when they rotate through our ALS clinic, our residents, making sure to tell them that really what we want, don't hold on. If you think patient has ALS, just send, we will figure it out. You don't have, we will decide whether they have ALS or no. Don't worry about making sure you do. They don't want to send a patient and the patient end up not having ALS, for example, and that could be devastating, right, for the patient. But I don't have an answer for you, but I can tell you that it is people from all sorts are looking at this in a very kind of profound way to resolve this issue. It's a big issue.
Yeah, that makes me think, you know, at my job in the hospital previously, we used to say there's no such thing as a bad referral. You know, if you have an inkling, if you have a suspicion that maybe this might need to be pursued, put the referral in, and then let the experts from there kind of figure it out. Yeah, I think that's really, really good advice. Somebody has some questions about limb onset ALS. Do we have any specific genes associated with that, or are there any specific studies that are looking at limb onset?
It's a good question. We don't know exactly what makes patients start in a specific area. We do, for example, know that patients who are SOD1 tend most likely to start in a leg, for example, but that's not 100%. That our patients who have SOD who can start with hand weakness or with speech change, it's more rare. We do know sometimes that patient with C9 may start more with bulbar disease versus limb onset, but it's not 100%. We do not know what causes that. That's one of the kind of the gaps in our knowledge. There is, fortunately, we're a little bit like a Swiss cheese in what we know about ALS. There are these gaps, and we need to kind of resolve them, and that is one of them. That is important. If you have a clinical trial and you put a leg onset patient there and a hand onset patient there, are they exactly the same patients? We don't know.
Another thing that seems to be coming up again is that question around genetics. And so I guess a two-part question here. Somebody has questions about kind of the importance of genetic testing and how that might relate to clinical trials. And then are there any studies that are looking at family offsprings of somebody who had ALS?
Yeah, so genetic testing, we do know in the past now, I mean, in the past 3 years at least, we started doing genetic testing on all new patients. It's important. And we definitely want to identify patients who have SOD1 because they would benefit from a completely different treatment. Even though they are rare, if we don't look, we will not find them. So it's very important, even in patients who don't have family history, because sometimes parents may die from other things, or sometimes the disease may not manifest exactly in the parents like it will do in the children. So even in the absence of family history, it's important to test for, to do genetic testing. The genetic testing also tests for other more rare genes, not just the one that we know more about. And it's important. It will help when we enroll somebody in clinical trial. Most clinical trials now do also genetic testing. It will allow us to go back and look at patients, maybe like I showed in that Lithium study. If we didn't have that genetic information, we wouldn't have known that there is a subgroup of patients that may benefit. So when we do a clinical trial, and even a clinical trial that is negative, we usually go back and do what we call post hoc analysis. It's not good. I mean, you cannot use that and say, oh, I found this, then the drug works here. But that is very important to design other study. And you go back and you look at the different gene changes. And maybe there is patient with a certain kind of gene that they will respond better to a certain drug. We will not know that ahead of time. We will know it, after. And that will allow us to go in the future, do another trial targeting specifically those patients who have this gene change. Now, of course, doing genetic testing, especially for patients who don't have family history, can be distressing. And you need to work with a genetic counselor, because if you end up being positive, there is implication for the next generation. Your children may carry the disease. They will have a chance of 50%, basically a toss of a coin, whether they have the disease or no. So that conversation should happen before just doing genetic testing. We do not recommend just doing genetic testing like that. It has to be done through the proper channels so we understand the results. The other problem with genetic testing is sometimes it's great when it's negative. It's great if it shows a gene. At least it tells us something, gets us closer to that needle in the haystack. But sometimes we do have patients who have variant of unknown significance. There is a change in their gene that we really don't understand what it means. We don't know if it's nothing we shouldn't worry about, or we don't know if we actually should worry about. And we sometimes have to just wait, hold on to that and wait, because research down the line, 2, 3, 4 years, will tell us more information about that change. So you do have to work with a professional who can explain what the results mean.
That's fantastic advice. And if you have access to a genetic counselor, or if you need help with that, feel free to reach out to me. I'm happy to share some of the resources we have. And again, as I previously mentioned, we do have a new decision tool that can kind of walk you through genetic testing and genetic counseling. Dr. Driss, would you be able to talk a little bit more about the ATLAS study at Northwestern?
Oh yeah, I forgot that. I was going to talk about that. Thank you. So yes, thank you very much for reminding me. The SOD1, the VALOR study was in patients symptomatic who had disease, who had ALS. They were based on Tofersen. But the fact that we can see that we can maybe help patients with SOD1, the question is, can we do it before the disease happens? Can we prevent the disease from happening altogether? Or even if it happens, can we make it slower because we intervene very, very early? So one good thing that the patients who are part of this family have is they can do what we call pre-symptomatic genetic testing. And again, you cannot do pre-symptomatic genetic testing by yourself. You want to work with a genetic counselor first. There is a tremendous, tremendous kind of anxiety that comes with trying to figure out if you carry like a deadly disease or no. So it's important to do that through the proper channel again. But patients who test for the gene and find that they are positive, we call them pre-symptomatic. They don't have any manifestation of the disease. Depending on their mutation, because there are 17 mutations with a fast progression that are included in the study. Not all SOD1 mutations, just 17 of them. So if you happen to have one of these 17s, you could be enrolled in the ATLAS study. And ATLAS study has multiple parts. You start in part A when you are observed. We do blood tests. We follow the neurofilament level. And if the neurofilament reaches certain threshold, we can start the Tofersen. And we do it placebo-controlled for 6 months, and then there is an open phase. Now, during that period of time, if the patient happen to develop symptoms and the neurofilament are not elevated for some reason, they get enrolled in the Tofersen arm then. So it is good. I mean, it's very important. So call for family with familial ALS out there. If you guys have any question about this ATLAS study, about what to do about pre-symptomatic testing, make sure to reach out. It's still enrolling. It will close soon, so it's not going to be enrolled running forever, unfortunately. And it's a very good opportunity to understand really if we can change the course of the disease if we intervene very, very early.
Fantastic. Thank you so much, Dr. Driss. I do want to be mindful of everybody's time, so we're a little bit over. So if I didn't get to your question directly, please don't worry. I will reach out to you directly with an answer for you. So I've been keeping track of those. Before we go, I just want to let you know about our next learning series. That'll be Thursday, August 17th, a little bit of a different time. So this is going to be at 7 p.m., but that is because we were so excited to share with you a wonderful researcher out of Australia, Dr. Samar Awan, who's going to talk about how we can support people living with ALS, their caregivers, throughout that process. So stay tuned for that. Again, thank you so much, Dr. Driss, for your participation today. Thank you all at home that are tuning in. We really appreciate it. At the end of this webinar, you will get a survey. Please fill that out. It really helps us produce the best materials that we can for all of you. And if you need anything else, please reach out to us. LesTurnerALS.org is our website. You can also find us on social media. And we look forward to seeing you in August. Everyone, until then, please stay well, and we look forward to seeing you soon. Bye.
Bye, everybody.